15 years ago, he first showed the role of complement in atypical hemolytic uremic syndrome, and this year shows the culmination of the last 15 years of work with the successful treatment of AHUS with Rituximab, and the publication 2 weeks ago in the New England Journal of that paper. Tim.
Thanks, David. So what I want to do over the next 15 or 20 minutes is tell you what treatments are available specifically for treating this group of diseases we've been describing today. What I'm not going to talk about are the general treatments that many patients with renal disease are used for, such as low potassium diets, phosphate binders, antihypertensives. I want to speak specifically to treatments that may change the natural history of the diseases. So I want to sort of give you a simple framework on which I'm going to put these various treatments on. So I've made a sort of very simple cartoon of what I think is happening in this disease. And what I would suggest to you, at the heart of this is overactivity of the complement pathway that Matthew Pickering described earlier on. And there are two ways in which I believe this complement overactivity comes about. First of all, you could have inherited genetic faults, mutations, that affect the genes that encode some of the proteins that are responsible for the complement pathway. This is probably rare. In the UK, I suspect there are less than 5 families where more than one individual in the family is affected by the conditions we've been talking about today. So inherited is rare. I think what's more common is what we would call the acquired autoimmune conditions. And you've heard already about an autoantibody called C3 nephritic factor, and I suspect some of you have been told you may have this. What this antibody is an autoantibody that results in complement overactivity. So the brake is off, as Matthew said, with complement, and what this results in is deposition of complement in the filters that Edwin described to you earlier on that provide the pivotal, they are absolutely crucial to kidney function. So the kidneys are just highly efficient filtration systems, and those 2 million glomeruli that we have produce about 150 liters of filtrate per day, and that's what we call the glomerular filtration rate, and that is the gold standard of renal function. This deposition of complement results in inflammation within these filters, and that, if unchecked, will go on to result in death of those glomeruli, and that cannot be recovered and will eventually lead to kidney failure. So let's look at some of the drugs that are used in the treatment of this condition and try and put them on this framework. So by far the commonest treatment that I suspect many of you have received here are steroids, corticosteroids, prednisone. Undoubtedly, probably the most powerful anti-inflammatory agent we have, used for many, many, many conditions with great success, but associated with numerous side effects if used over a long period of time. So I've given you a list here: weight gain, diabetes, thinning of the bones, high blood pressure, muscle weakness, increased risk of infection, and stomach ulcers. So taking steroids over a long time, although very effective for many diseases, is not without risk. So where on my framework would I put steroids? I think I put them down here in preventing inflammation within the glomeruli. They may affect at other levels, but this is the primary level that I think they're affecting. Okay, I'll come back to steroids again a little later. What about some other drugs that are commonly used? Cyclophosphamide. This will probably be the second-line agent that individuals in the UK are given at the present moment. It's been used both as an anti-cancer drug and it depresses the immune system. The way it works is it damages the DNA of cells that are turning over very quickly. So cancer cells turn over very quickly, they proliferate, they increase in number very quickly. So this is an ideal drug to damage the DNA and destroy those cells. Immune cells, which produce some of the side effects that Kevin mentioned, are also very fast turning over cells. And so this is an ideal drug to target immune cells. Numerous side effects with cyclophosphamide, the least of which is risk of infection. It's something we look very closely for in patients who we put on cyclophosphamide. So where on my framework would I put this? So I put it at 2 levels. So cyclophosphamide will not only affect the inflammation, but it also will dampen down the production of autoantibodies such as C3nef. So that cyclophosphamide is used in a lot of autoimmune conditions. Okay, What about other drugs? Well, another drug that some of you may be on is called mycophenolate mofetil, MMF. And this is a drug that inhibits the growth of T cells and B cells, those immune cells that Kevin mentioned earlier on. It's used in a wide range of other conditions, so we use it very widely in kidney transplantation because of its immunosuppressive effect. Also used in a wide range of autoimmune diseases. And again, the major side effects, as with all immunosuppressants, is the risk of infection. So let's put this on my framework. Again, I put it very similarly in the place that cyclophosphamide is. Here, preventing production of autoantibodies, and again, the anti-inflammatory effect down here for its effect on B cells and T cells. Okay, what about another drug that you may have heard about called Rituximab? As I talk, the drugs are becoming more expensive. So Rituximab is one of those antibodies that we call a monoclonal antibody. It's an antibody that we produce in cells, and it's a specific antibody that destroys B cells. And B cells are those cells, one of the role of which is to produce autoantibodies. They will produce antibodies. So by destroying those B cells, we will prevent the production of autoantibodies. And B cells, as I say, are responsible for producing C3F. Again, risk of infection. Every time we depress the immune system, there's this risk of infection. So let's put Rituximab in there. So I put them, you can see the way they're lining up. So I put Rituximab in here, preventing the production of C3F, and it's been used previously in many patients for this, and also down here for its anti-inflammatory effects. Okay. Next thing, plasma exchange. I would be astonished if there are not people here who have not undergone plasma exchange. So this is a simple cartoon of what happens in plasma exchange. Here's your body. You'll need some access into a vein. Most people will have a catheter put into a big vein. Some people will plasma exchange on a fistula, but most people will have a catheter. The blood's taken out, and in a filter, in the plasma exchange, your plasma is removed, about 3 liters at each time for an adult, smaller in children, and donor plasma is given back in. What's the benefit of doing this? What's the idea? Well, the two principal things that we're doing. If you have an autoantibody, such as C3F, removing it, which is in your plasma, will take away that autoantibody. Unfortunately, it's going to come back, and it sometimes will come back quite quickly. At the same time, in the donor plasma contains many of the very good complement proteins that can dampen down, put a brake on the complement system, as Matthew told you earlier on. So it's two effects. So let me show you again on the cartoon where I will put plasma exchange. So I'm going to remove autoantibodies, but for the first time, we're starting to see something that directly targets complement overactivity in a pretty non-specific way. There are multiple problems with plasma exchange. Access problems, allergic reactions, and there are many patients who are on long-term plasma exchange who cannot continue it because of such problems. So in many patients, it's not a long-term therapy. I'm not going to go through an existing list because I could keep on adding more and more drugs to this list. So I'm going to add a few more, but not go to them in great detail. So let's add in now Tacrolimus and Cyclosporine, 2 drugs that we use very widely because they're immunosuppressants. We use them very widely in kidney transplantation. So for the same reason, they're going to be beneficial in autoimmune diseases and in inflammatory conditions. And I, again, would be astonished if some of you here have not been given Tacrolimus or Cyclosporine. What about other drugs that have been used? Well, antiplatelet drugs have been proposed as a treatment for this condition. So some people may have received aspirin, a drug called dipyridamole, and also warfarin. So a large number of drugs have been used in the treatment of these conditions. How do we assess if these treatments are of any benefit? So sometime we will see a drug which we think, that would be a really good drug in this condition, and we will say, well, we're going to give it to a patient. And that becomes an anecdote. And so case reports, one person treated as an anecdote, and a series of anecdotes may start to convince us, if that drug is successful, that it's a good drug to use in a condition. But you have to remember, when you've treated one patient with a drug, you're not really certain whether it's chance that that's worked, or is it that drug? So more than one patient, we get a series. And once in a series of treatments, you start to see a beneficial effect. You start to think, this could be a good drug. But it still doesn't prove that that drug is the right drug. The gold standard that we should always be trying to do as clinicians is what's known as a randomized controlled trial. So simply a randomized controlled trial is we have a drug, and we have the standard treatment, and we randomize individuals to either carry on a standard treatment or receive a new drug. And we look for enough patients to be able to see if there's a difference. And we were talking about maybe up to hundreds of patients in 2 limbs of this. So what measurements in this condition would we actually be monitoring to see if there's a benefit? So we undoubtedly would want a measurement of renal function. As I've said to you already, glomerular filtration rate is the gold standard. And the way we estimate it is by measuring creatinine, and you've probably heard sometimes from your own clinicians that we, from that, derive a figure called the estimated glomerular filtration rate. So that's going to be a measurement of your renal function. We might also want to look at the amount of protein in the urine. That isn't an absolute measurement of your renal function. It is probably an estimate of the inflammation or the damage that's going on in those filters. So we'd like to see the amount of protein in the urine coming down with time. Obviously, one of the things we'd really like to do is to do another biopsy. To make a diagnosis of these conditions, you really need to have done a biopsy. So for somebody here who's been told that they have MPGN or dense deposit disease and they've not had a biopsy, it's probably going to be that diagnosis has been made on specific blood tests that make you think of it. But we really would need to do a biopsy on everybody to be absolutely certain. And it would be a good way. But biopsies are not without risks themselves. So only in certain conditions we'll be doing repeated biopsies. So I told you that the gold standard is a randomized controlled trial. Has there ever been a randomized controlled trial in any of the diseases? Yeah. Well, yes, there's been one. And this is the one randomized controlled trial done by a group of pediatricians in mesangiocapillary glomerulitis at that time, and the treatment was alternate day prednisolone. So 80 patients entered this study. And the randomization didn't quite right because you'd expect 40 to go to prednisolone and 40 to go to placebo. The placebo was a drug, lactose, a sugar. So people didn't know they were getting the placebo and they didn't know they were getting the prednisolone. That's what we call a randomized blind controlled trial. And they were given alternate day prednisolone, and this is the dosage, 40 milligrams per meter square body surface area. And the mean treatment period was a long time, 41 months. Because many of these diseases are very chronic diseases and take a long time for the actual thing to manifest, you have to follow patients a long time. So here we have 10 years worth of follow-up for these individuals. So here is what happens to the treatment group. And along this graph here is the percent of patients who do not develop kidney failure or a manifestation of kidney failure. So the treatment group, 61% by 10 years after they'd started treatment, had not developed kidney failure. Alternatively, in the placebo group, only 12% of the group who had not received steroids had not developed some measurement that suggested that kidney failure was imminent. So I think from this is pretty good evidence in this randomized controlled trial that steroids were beneficial. For all the other agents I've shown you, there has not been a randomized controlled trial. There have been individual series which seem to suggest for drugs like Cyclophosphamide that there is a benefit, but there is a need for us to do randomized controlled trials for many of the agents that I've shown you already. How do we as clinicians decide whether there is enough evidence to give somebody a drug? Well, luckily, we have groups of international experts who come together and write guidelines for us. So this is the guidelines that is written by the World Society of Nephrology, and it's called the KDICO Clinical Practice Guidelines for Glomerulonephritis. And the diseases I've we're talking about today are all forms of glomerulonephritis. So let's see, these very august senior people all came together and they looked at every publication that there ever had been about these diseases. Let's see what they said about this disease, membranoproliferative glomerulonephritis. So they suggested that every patient should have a renal biopsy, which I've already mentioned. Well, this is what they said about the treatment. We suggest that adults or children with presumed idiopathic MPGN, accompanied by nephrotic syndrome and progressive decline of kidney function, receive oral sacrifice or MMF plus low-dose alternate day or daily corticosteroids with initial therapy limited to less than 6 months. Now, when a group comes together like this, they try to give some weighting. How strong is the evidence? So the evidence, the weighting they give is a 2D weighting. Let me show you what 2D means. So the 2 recommends to the grade. So level 2 means we suggest the majority of people in your situation would want recommended course of action, but many would not. So that's the interval patients. The clinicians, for our different choices, will be appropriate for different patients. Each patient needs help to arrive at a management decision consistent with his or her values and preference, and the recommendation is likely to require substantial debate. So that's the sort of a level of support you can give to the grade. What about the grade here for the quality of medicine? Remember, this was 2D that I said, the evidence. 2D is very low. The estimative effect is very uncertain and often will be far from the truth. So this is what we as clinicians are presented with at the present moment. Now, I'm trying to be truthful with you. I want to give you the honest appreciation of where we are at the present moment in treatment of this condition. So the evidence for a lot of the treatments we have at the present moment is not as strong as we would like it to be. So let's look into the future. So perhaps, I hope I haven't made you too pessimistic, but I want to try and be a little bit optimistic now. I do believe that most of the things I've told you about at the present moment are attacking what I call non-specific areas of this pathway. If I had to go for one area, I would go for the complement overactivity. That's where all the abnormality is. That's what we should be addressing. And I've told you about plasma change. So what about complement inhibitors? Where are we at with developing complement inhibitors? So, as Matthew said, there is currently only one complement inhibitor that is licensed. There are lots in production. That is Eclusumab, Soliris, and monoclonal antibodies. Now, Alexion make this drug, and they're sponsoring today, so I hope you will trust that I'm not being overly optimistic about a drug that they are sponsoring today. I'll try and tell you what I feel is the honest truth. It's a biological treatment, monoclonal, first licensed in 1986, and monoclonal antibodies are used in a large number of treatments at the present moment. It is licensed to treat 2 other complement diseases, paroxysmal nocturnal hemoglobinuria, PNH, and atypical hemolytic uremic syndrome. In both those conditions, there is now very good evidence that Eclusumab is a highly effective treatment for these conditions, in some patients life-threatening and certainly transforming the lives of patients. So, what about the use of Eclusumab in the diseases we've been talking about today? So the outcome has been reported in the literature in 10 patients. 4 of them had recurrent disease post-transplantation, and with Eclusumab, using the things I've already mentioned, there was evidence of an improvement in 7 out of the 10. 3 of whom did not show an improvement, but those 3 did not seem, on the blood tests that we did, to show evidence of complement activation being excessive. Okay, so we're very lucky that in the audience today we have one of those 10 patients. So I am now going to go. So, this is Tara, and the first thing I want to say to Tara is thank you so much for agreeing to be interviewed by me today, and thank you for coming all the way from Belfast. So, Tara, you developed dense deposit disease at, I think, the age of 8, was that right? But dialysis wasn't necessary till you were 20 or so?
20, yeah.
Yeah. And you went into what form of dialysis at that time?
I went to peritoneal dialysis. I done 6.5 years of home dialysis, and then the rest was, I done 10 years altogether, and the rest was hemodialysis.
Okay. And then you got a transplant?
Yeah, my brother gave me a kidney.
Okay, well tell us what happened with that transplant.
I got a transplant in February 2011, and a month later I took rejection. My disease was trying to attack the kidney again. I done 4 weeks of continuous plasma exchange, which didn't work, so the last resort was the Eclusumab drug, and I've been on it since April last year, and it has worked very well ever since.
So I think it's fair to say that there was evidence that your kidney function of a transplant kidney was not going well at the time you started the Eculizumab, and it seemed to reverse at the same
straight
time.
Away.
I think also there was a time when the Eculizumab was withdrawn because everything seemed to have got better. What happened when the Eculizumab was withdrawn?
I stopped taking it for about 6 weeks, and my creatinine started moving up and up. It went up to about 430, and then I started straight back on it every week, and it went down to about 140, and now I'm on it every other week, now every fortnight. And
so you had the Eculizumab every other week, and it's just, how long do you come in for? Do you have it at home?
45 minutes.
Yeah, it's just a drip for 45 minutes? Have you had any side effects at all with it?
At the very start, I took very, very sore knees and couldn't walk really well, but then I got a steroid drug into them, and I've never had the pain again.
Okay. And what's your creatinine now, do you know?
154 last Friday.
154, so that was down from a peak of over 400 when, and you had a biopsy, I think, to show that the dense deposit.
I've had 2 biopsies ever since.
Okay. Well, it's fantastic, isn't it?
Yeah.
Great. Well, I'm going to thank you very much.
Thank you.
So that's really encouraging, isn't it, to hear that that's happened in Tara's case. So I'm going to come back to Eculizumab again in a minute. So what does our world experts think we should be doing? Well, they think we should be doing some randomized controlled trials, something I completely agree with. They think we should be doing corticosteroids plus an immunosuppressive agent like the cyclophosphamide MMF, or even Rituximab. I think that we do need a trial in complement inhibitors because although I'm pretty convinced that it's the Eculizumab that changed the outcome in Tara's case, particularly so because when a drug is withdrawn and then the disease comes back and then you reintroduce it and things get better, that's very strong evidence. So I think there's beginning to be good anecdotal evidence that we should be using doing a trial in Eculizumab. The long-term history of these diseases is, as you can see, it could be 10, 20 years. Transplantation may be an ideal way to look at the efficacy of complement inhibitors because if it comes back, it tends to come back more quickly. So this is a study looking at the recurrence of dense deposit disease post-transplantation, and this was the North American experience in pediatrics. So I'm going to show you 3 graphs here. So this is what happens to the graft survival, and so that's percent. So these are all patients in this registry of patients undergoing kidney transplantation, minus those patients who've got dense deposit disease. Here are the patients who've got dense deposit disease. The take-home message is that at 5 years, 74% of people who do not have dense deposit disease have still got a functioning transplant. Compared to dense deposit disease, 50% have a functioning transplant, and the 50% who don't have a functioning transplant have usually lost it due to recurrence of disease. To see whether this was a true effect, they then went back and did a retrospective study and looked at all the cases that have been reported in the literature. So you've got that same curve there, and superimposed here is all the things, individual cases that they could find. And again, it's remarkable how the two are overlaid. So about a 50% 5-year survival of the transplanted kidney. What I found was really interesting, I can't explain that, is that when you looked at people with dense deposit disease alone and compared those patients who got it from a cadaver kidney compared to those patients who got it from a living donor, the outcomes seemed to be better in those patients who got a living donor who had dense deposit disease compared with a cadaver. Although Tara's just proved me that one wrong in that sense. So it just shows you have to put a lot of cases together to get a true picture. So, in conclusion, as I said, I hope I have not been overtly pessimistic in what I have presented to you, but I wanted to present to you what we know about the treatments. I do feel, however, the advent of complement inhibitors, and from what we're seeing of Eculizumab, is a sign of the future to my mind. I will be surprised if in 5 years' time we're using Eculizumab specifically for dense deposit disease here. But it shows, it's evidence that targeting the complement pathway could be a really effective treatment with very low side effect. There's only one significant side effect associated with eculizumab, and that's a rare form of meningitis called meningococcal disease. And we specifically addressed that, and we've had no outbreaks, no cases that reported in the UK. So whilst I'm slightly pessimistic about the past, I'm really optimistic about the future with complement inhibitors. Thank you very much indeed.
Have any questions?
At what stage of the disease would you give complement inhibitors?
The current recommendations for all the treatments that I've discussed right now is that you would be giving any of those treatments when there is evidence of a progressive decline in kidney function. So if I have somebody whose kidney function is stable and almost normal, and we know on biopsy has one of the diseases, I'm not going to be treating them with it unless I start to see evidence of that. I suspect initially that's what we were doing. I don't know that we will be using complement inhibitors in people who appear to be very stable at the present time.
Can I just ask, probably goes on from the last question, to what extent you would wait until a patient is given the eculizumab? Because I've read that the sooner the drug is given, the better the outcome. It's playing one off against the other, isn't it?
So in atypical hemolytic uremic syndrome is a disease that we have much more experience in using eculizumab in. And this is a disease that causes kidney failure within a matter of weeks or days. In that disease, there is evidence that the sooner we get eculizumab to somebody, the more likely we are to prevent them developing kidney failure that will need long-term dialysis. In this condition, that might take a long period of time before somebody, 10 years in some patients before they were developing kidney failure. Are we going to give 10 years worth of a complement inhibitor? And I just don't know the answer to that at the present moment.
Can I ask Tara what her symptoms were, or how bad her symptoms or numbers were before she was allowed to, or before she was put on the drug post-transplant?
The creatinine was sitting about 460 when I was put on the drug, but it was the last, my kidney was failing. It was the last straw. I was going to be put back on dialysis and remove the kidney.
Have you got a post-transplant creatinine
I was
figure
sitting
before
about
you went up to the
about 85.
And that was quite short time
Yeah.
difference, wasn't it? Yeah.
Yeah, a month.
Nice to see you here.
Thank you.
Right.
Okay, thanks.